Thank you very much.
Thank you, Dr. Heba. So let's start our first session, which will be about upper GI diseases. We'd like to invite our chairs for the session, Dr. Ali Al-Baqali from Bahrain, Dr. Fahad Al-Najjar from Kuwait, Dr. Hussein Al-Amin from Egypt, and Dr. Samir Al-Awadi from United Arab Emirates. Please join me to the stage.
So we will start with our first session with GI bleeding in cardiac patients. So the first presenter, Dr. Al-Ali, he's an assistant professor in the Department of Internal Medicine, Kuwait University, and consultant gastroenterologist at Thanayan Al-Ghanem Center. Dr. Al-Ali undertook his internal medicine and gastroenterology residency training at the University of Toronto. He did 2 advanced therapeutic endoscopy fellowship, EUS and ERCP, at McGill University and University of Toronto. Dr. Al-Ali and Dr. Al-Ansari, Dr. Yahya Al-Ansari is a senior specialist, interventional and endovascular cardiologist at Sabah Al-Ahmed Cardiac Center. Dr. Al-Ansari had his internal medicine and cardiovascular medicine at University of Miami, Florida. Cardiology fellowship at McGill University, intervention cardiology and endovascular intervention fellowship from Asnan Hospital, South Korea. Dr. Al-Ansari.
Assalamu alaikum. Good morning, everyone. I'd like to thank the organization committee for the kind invitation. And what a way to start a gastro conference with a cardiology lecture. So I'll try to be concise and hopefully to the point. All right, I have no disclosures related to this topic, and this is what we're going to go through in this short talk. Pretty much I'm going to talk about the current antiplatelet and anticoagulation guidelines. In acute coronary syndrome, elective PCI, valvular diseases, especially mechanical, and the new kid in the block, which is TAVI. It's not new anymore, but this is the vibe right now. And few words about atrial fibrillation. All right. So, during this talk, we have a recent guideline, especially the European Society of Cardiology, and the American, we have the 2021 and 2022. There are a few differences, so I'm just going to go with the most updated one. All right, so acute coronary syndrome. We all know that all patients need to be in aspirin, and previously all patients to be in dual antiplatelet therapy for at least 12 months. With the more potent antiplatelet therapy, we are trying to shorten the duration, especially in high-risk patients. So if the patient has low risk, then DAPT for 12 months, and this is class 1 indication. But if the patient has high risk, even if it's ACS, and they specify in the guidelines that high-risk patients either history of GI bleeding, history of peptic ulcer disease, or if he has blood score 3 or more. We use this score mainly for anticoagulation, but in the new guidelines, they threw it also for dual antiplatelet therapy. So what do we do if the patient has high-risk group? It's on the next slide. But if he doesn't have, then we stick with 12 months. PBI is a class 1 recommendation for high bleeding risk, and class 2A for all patients. The Americans, they usually use it for all patients as well. All right, this is a new thing which was published in 2023. It's a new alternative antithrombotic therapy regimen for high bleeding risk. So, single antiplatelet therapy can be considered after 3 to 6 months. So you'll do with dual antiplatelet therapy, and after 3 to 6 months, you can change it to single antiplatelet therapy, and preferably is B2Y12 inhibitor, which is clopidogrel or similar. There is also another recommendation, which is a class 2A, but after 1 month of dual antiplatelet therapy, you can change the patient on aspirin or B2Y12 inhibitor. It's still less, the recommendation is 2B, not 1, not 2A, but it's still considered in high-risk patients. Previously, if it's ACS, no matter, you have to continue for 12 months. Now, these are new guidelines based on multiple studies. This is just an illustration of the guidelines in patients with high risk and only in high risk. After dual antiplatelet therapy with 1 month, you can start single antiplatelet therapy. And this is very useful for a patient who has high risk of bleeding previous, or even if he developed bleeding during the antiplatelet therapy. All right. And what about in patients who requires oral anticoagulation? Of course, if the patient is required oral anticoagulation, what they recommended is triple therapy for 1 week, and then to change it to Plavix plus oral anticoagulation for at least 12 months. And this is class 1. Class 2B is dual antiplatelet therapy or oral anticoagulation and oral anticoagulation B2Y12 inhibitor for 6 months, and after 6 months changing the patient to oral anticoagulation alone. And they less favor the potent B2Y12 inhibitor to be used, like ticagrelor or prasugrel, because they are more risk of bleeding. And in case you want to use the oral anticoagulation and the B2Y12 inhibitors, you can use the reduced dose as well. These are all new guidelines. What about elective PCI? Elective is much easier, and I'm just going to focus on this, the one on the right side, which is high bleeding risk. So pretty much if the patient has high risk, you can give him dual antiplatelet for 1 month, and after that, single antiplatelet therapy. We tend to use at least 3 to 6 months previously, but now we reduce it to even up to 1 month, because we believe that after 1 month, the whole stent is going to be endothelialized and the risk of thrombosis is less. All right. What about valvular diseases? The guidelines that we have is in 2021, both the European and the American. And we have 2 types of valves, mechanical or bioprosthesis. So bioprosthesis including TAVI. There is no mechanical TAVI, all right? So mechanical valves, there is no doubt you have to use vitamin K antagonist. You can't use oral anticoagulation, NOACs or DOACs, and aspirin is only indicated if the patient has a previous history of coronary artery disease. All right? For bioprosthesis, what we tend to use is if the patient has other indication of oral anticoagulation, then he's going to be on oral anticoagulation without the need of aspirin. If the patient is not, then the European and the American here, they have different opinion. The European is saying long-term single antiplatelet therapy and the preferred aspirin. The next slide is going to be the American, which showed it depends on, again, if the patient has any other indication for antiplatelet therapy. For example, if he has a previous PCI, then you will do dual antiplatelet therapy according to the PCI regimen. If there is indication for oral anticoagulation, you're going to continue the oral anticoagulation. But if there is no indication either for PCI or oral anticoagulation, then you will use DAPT or single antiplatelet therapy for 3 to 6 months only. So this is the difference between the American and the European. The American said only 3 to 6 months. The European is indefinite using aspirin. All right, I think I'm almost there. Finally, atrial fibrillation, and what is new in atrial fibrillation? We developed a new score, of course. It's CHAD-VASc, not CHAD-VASc. We took out, or they took out, the gender. So same score, except there is no point for the gender. And they clarified about the scoring and what is the class of indication. So if your score is 2 or more, that's class 1 indication for oral anticoagulation. If your score is 1, that's class 2A to start oral anticoagulation. And they specified that NOAC is preferred over vitamin K antagonist. And finally, antiplatelet is not recommended as an alternative to oral anticoagulation therapy, and this is class 3. And just one point to know, it's an annual risk, it's not a daily risk. So if the patient is having bleeding, stopping the anticoagulation for 2 or 3 days shouldn't be that big deal, because it's 1.9, let's say an example is, it's 4% annual risk, it's not daily risk, all right? And by that, I think I'm done with the presentation.
So it's a pleasure to be standing here again in KGA, and today I'll continue the talk which Yahya started, which is about the GI bleeding in cardiac patients. So we've heard about the antithrombotics that are used in patients with cardiac disease. We know that the use of antiplatelets, antithrombotics in general, is increasing in the population, and we know this comes with a risk. So GI bleeding is an important adverse event of the use of antithrombotics. And at the same time, we know that patients who develop GI bleeding, they tend to be less compliant with antithrombotics after their event, and this is associated with increased morbidity and mortality. So what to do in this case? So whenever we see a patient who requires antithrombotics, we know there is a risk of bleeding. Again, risk of GI bleeding. But at the same time, we know if the patient who requires a antithrombotic is not placed on antithrombotics, there's always a risk of thromboembolic disease. And an important message to deliver here, whenever it comes to balancing the risk and benefit of antithrombotics, cardiac risk, so the heart always takes priority over the GI bleeding. GI bleeding, yes, it is associated with morbidity, less so mortality, but we can almost always manage it endoscopically. However, thrombotic events have catastrophic consequences. So a patient develops massive MI, stroke, or a PE. Obviously, this is associated with a much dramatic morbidity and potential mortality compared to a GI bleeding. So what to do? Now we have guidelines to guide us how to manage antithrombotics in patients who develop GI bleeding. And the first guideline comes from the American College of Gastroenterology and the Canadian Association of Gastroenterology. And the second one is from the European Society of Gastrointestinal Endoscopy. For the most part, both agree on the principles, so I will just review some of these recommendations. So these are the agents that we commonly encounter in patients who present with GI bleeding. We have antiplatelet agents, we have vitamin K antagonists, specifically warfarin, and we have several new, who are not really new anymore, DOACs. When I talk about the management, I will discuss each of these scenarios. The first scenario, or even when we talk about what to do in a specific scenario, whenever we have a patient with a GI bleeding, irrespective whether they're taking antithrombotics or not, the principle of a treatment remains the same. Resuscitation remains the cornerstone of management of patients with GI bleeding. We know that airway protection and adequate fluid resuscitation to improve and increase the tissue perfusion is essential because it's one of the very few things we can do in patients who have GI bleeding, which has been shown to reduce mortality. We know endoscopic therapy does not decrease mortality. We know a lot of the things we do in GI bleeding does not reduce mortality. However, adequate resuscitation is associated with reduced mortality. So this doesn't change among patients who present with GI bleeding, even if they take an antithrombotics. What about blood transfusion? In general, the guideline says restrictive blood transfusion is appropriate for most patients with GI bleeding. However, this is not appropriate for patients who have underlying cardiovascular disease. Because if you adopt a restricted blood transfusion strategy, which is transfusing the patient if the hemoglobin is less than 7, this has been shown to increase the coronary events in patients with underlying cardiac disease. And because of this, the current guidelines suggest to adopt a liberal blood transfusion strategy. But what do we mean by liberal? Essentially, you only transfuse if the hemoglobin is less than 8, with the aim to keep the hemoglobin around 10. So there's a subtle difference, but in patients with underlying cardiac disease presenting with GI bleeding, you should transfuse if their hemoglobin is less than 8. All right, the first scenario, patient on aspirin. This is very common, but luckily it's very easy. In general, if the patient is taking aspirin, for the most part, you do not need to hold the aspirin even if they present with a GI bleeding, with one exception. So if the patient is taking aspirin for primary cardiovascular prevention, it should be stopped, but it should be stopped indefinitely because there are now strong, high-quality data suggesting that aspirin as a primary prophylaxis for cardiovascular disease does not reduce mortality, and in fact, it is associated with increased GI bleeding. So this is the only scenario where you should be stopping the aspirin. and it should be stopped indefinitely. But if the patient is taking aspirin for secondary cardiovascular prevention, in general, you do not need to hold the aspirin even if they present with GI bleeding. If for whatever reason the aspirin was stopped, it should be resumed as soon as possible, ideally within 5 days, to reduce the morbidity and mortality of prolonged stopping aspirin for a prolonged period of time. So, in general, as I mentioned, you don't need to hold the aspirin, but if it was held for whatever reason, you can risk stratify the patient based on the endoscopic stigmata. So, if the patient undergoes endoscopy, and the initial endoscopy shows a low-risk lesion, peptic ulcer disease, which is non-bleeding, so a clean base ulcer, Forest 3 or 2C, which are considered low-risk lesions. In this case, you can resume the aspirin immediately, and potentially the patient can go home the same day. On the other hand, if the patient, so again, this is the scenario where the aspirin was held initially, and if you perform endoscopy, you identify a high-risk lesion, so Forest 1A, which is a spurting vessel, or a non-bleeding visible vessel, essentially any scenario where you require endoscopic hemostasis. In this case, it is reasonable to wait for 3, maybe up to 5 days before you resume the aspirin. In other words, by the time where the patient is ready to go home after they finish their PPI infusion, probably this is a good time to resume the aspirin. But again, the bottom line, you don't actually need to hold the aspirin in the first place. So aspirin, very simple. What about dual antiplatelet agents? This is a more complex scenario because most of these patients have a significant cardiovascular disease, and this is a good time where you get your cardiologist, your neurologist involved. But again, the most important message, never stop both agents at the same time. This has been associated with high risk of stent thrombosis, increased morbidity. It is okay to continue the aspirin. So again, you kind of see a general theme here, which is continue the aspirin. In general, aspirin is not a big deal. You can continue the aspirin and hold the other antiplatelet agent until you do your endoscopy and risk stratify the patient. But in general, you want to resume the second antiplatelet agent soon after the endoscopy, usually within 3 to 5 days. Avoid prolonged delays in resuming the second antiplatelet agent. What about platelet transfusion? So we know antiplatelet agents affect the function of the platelets, not the number, but the function. So it makes sense to give functional platelet to the patient in the hope it will replace the dysfunctional platelet. But this practice actually has been shown to increase the mortality of patients in the absence of thrombocytopenia. So in general, you should not give platelet transfusion unless the patient has significant thrombocytopenia. Now, the definition of thrombocytopenia differs from guideline to another. The ACG/CAG guidelines recommend adopting a platelet count less than 100 at the threshold to transfuse platelets, but other guidelines use the threshold of less than 50. The bottom line, only give platelets if the patient has significant thrombocytopenia. So this is the first scenario, patient on antiplatelet agents. What about the anticoagulants? So we have several anticoagulants. We have several antidotes, including vitamin K, FFP, and specific DOAC antidotes. In general, and we'll talk about the specific scenarios when to use the antidotes. In general, keep in mind that DOACs have very short half-life, usually less than 24 hours. So these antidotes should only be used if the patient took the DOAC within the last 24 hours before presenting with a GI bleed. If they took the DOAC more than 24 hours before presenting to the hospital, then there is no place for these agents. So what does the guidelines say about these antidotes? So if the patient is taking warfarin, in general, in a patient with a stable, I want to emphasize the word stable GI bleeding, you don't need to do much really except for hold the warfarin on presentation. So if the patient has stable GI bleeding and have a therapeutic INR, so if the INR is between 2 and 3, if they're on warfarin for AFib, for example, in general, you don't need to do much except hold the warfarin, resuscitate the patient, and in fact, the guidelines suggest against giving vitamin K because it just takes too long to work. They suggest against giving FFP. They could not make a recommendation about PCC in general, but the bottom line the guideline says you don't have to do much except to hold the warfarin if the patient, again, has stable GI bleed and the INR is in the therapeutic range. If they have a super therapeutic INR, so INR of 6 or 7, this is a different scenario where you have to correct the INR according to the to other guidelines. What about DOACs? Same thing. You don't have to do much except to hold the DOAC in the case of a stable GI bleeding. You don't need to give the specific antidote. You don't have to do much except to hold it, resuscitate the patient, and within 24 hours, the drug should be out of their system. So far, everything is simple and essential. All I'm saying is you don't have to do much except hold the agent and wait and resuscitate the patient. But obviously, we have these reversal agents for a reason, and there is a room for these reversal agents in a very, very small subset of patients with GI bleeding. Essentially, these are the patients who have significant life-threatening GI bleeding. And there's a specific definition for a patient with life-threatening bleeding, which is shown on the right-hand side here. Essentially, these are the patients who present with hypovolemic shock from the GI bleeding. They have massive bleeding where they require pressors to go to the ICU, and they drop more than 5 grams of hemoglobin, or even required 5 units or more of blood. So this signifies a major GI bleeding. This is the subset of patient where you should be giving reversal agents, whether it's FFP, whether it's a DOACs or PCC, or a specific antidote for the DOACs. So as you can see, this is a very small subset of patients we see. The vast majority of patients we see are the stable GI bleeding patient where we just need to resuscitate the patient and hold the agent without giving any specific antidote. What about resuming the DOAC and warfarin, which is a very challenging scenario? There have been several studies looking at the timing when to resume the DOAC or the warfarin. In general, there's always this balance between risk of bleeding and thrombotic events. Yes, if you resume the agents early, which is within 7 days, there is a risk of bleeding, but your cardiovascular events and thromboembolic events rate goes down. If you have prolonged period of time before resuming the warfarin or the DOAC, you it's true you decrease the risk of bleeding, but you do increase the risk of cardiovascular events. So it's always a balance, but remember what I said initially, the heart always takes priority, and that's why the guideline says, in general, you want to resume the warfarin or DOACs within 7 days. They say, essentially, you need to avoid prolonged period of interruption of DOACs and warfarin. But if the patient has low risk of thromboembolic risk based on the CHADS-2 or CHADS-VASc score, you can resume the warfarin within 7 days. On the other hand, if the patient has a mechanical valve, for example, where we know their risk is very high, these are the subset of patient where you still want to resume it within 7 days, but maybe you should be considering giving a heparin infusion in case of warfarin. And keep in mind, if the patient is on a DOAC, DOACs work very quickly. So as soon as you give it, it will work. So you don't have to bridge, but these are the kind of patient or the subgroup of patient where you want to consider early resumption. So if you want to put it all together, this is essentially a summary of what I just said. If you have a patient with an acute GI bleeding who's taken antithrombotics, the first thing you want to ask, is the patient stable or not? Do they have a life-threatening GI bleeding or not? If they do, which is in the red boxes here, essentially these are the group of patients where you would consider reversal agents. In the case of warfarin, you want to give PCC. As we mentioned, vitamin K really has no role because it takes a little bit too long to work. And in the case of DOAC, you can give PCC, but ideally you want to give a specific antidote. On the other hand, if you have patient with stable GI bleeding, which is the vast majority of patients we see, you don't have to do much except resuscitate the patient, hold the agent, and that's it. For a patient on antiplatelets, so if they're on aspirin monotherapy, the easiest to manage. In general, you don't need to hold the aspirin at all, except if they're taking the aspirin as a primary cardiovascular prevention when it should be stopped indefinitely, but otherwise you can resume or you keep the patient on an aspirin. And as I mentioned, if it was held initially for whatever reason, you should resume it within 3 to 5 days. The dual antiplatelet arm is a little bit more complicated, and you should be involving the cardiologist and neurologist here. In general, never stop both agents together. You can hold the second agent, which is usually a P2Y12 inhibitor. Always keep the aspirin. And again, in either scenario, you always want to resume the antiplatelet agent within 5 days. So really, these are my conclusions, as I showed you before. And that's it. I would like to thank you for your attention, and thank you very much.